So we were interested in this population of patients because we know that among all patients with metastatic colorectal cancer, patients with BRAF V600E mutations often fare more poorly in terms of overall survival. So we were interested, kind of given, our belief that this might represent an immunologically unique subpopulation of patients with microsatellite stable colorectal cancer. There might be a role for combining targeted therapies, the standard of care, Encorafenib and Cetuximab, with the addition of an immunotherapy agent, in our case, Nivolumab. So we evaluated patients on our study with microsatellite stable BRAF V600E metastatic colorectal cancer who had had one or two prior lines of therapy for treatment of stage 4 disease. And, our participants were not allowed to have had prior exposure to BRAF, EGFR therapies, or immunotherapy either. But all patients on our study received the combination of Encorafenib, Cetuximab, and Nivolumab. And because this was something that had never been tested as a triple combination before, formally, we looked first at the safety to ensure that there was, a favorable safety profile for this combination. And once we found that, our study design was, a Simon two-stage design whereby, in the first 15 patients, we needed to see in the first 15 patients, if we saw 3 or fewer responses, then we would say early on that there was futility observed, and that the addition of Nivolumab didn't really appear to offer much beyond what we would expect with Encorafenib and Cetuximab alone. If we saw more than 4 or more responses in those initial 15, that would allow us to enroll 11 additional patients for a total of 26. And so as of January 2022, we have enrolled the full 26 patients onto the study. And we have thus far staged 22 of those patients for a response to Encorafenib, Cetuximab, and Nivolumab. Overall, the combination appears to be very safe and well tolerated. There were no patients who experienced in our initial cohort any dose-limiting toxicity, so we were able to use our initial dosing schedule as the one for all patients in our study. We also observed that there were no treatment-related deaths thus far because of treatment. And when you look overall at the safety toxicity profile, grade 3 or 4 treatment-related adverse events occurred in fewer than 20% of patients. So we feel that overall it was safe and well tolerated from our initial experience on our study here at MD Anderson. In terms of the results that we've seen thus far, I think very encouraging. In the initial 22 patients who have undergone assessment, radiographic responses have been observed in 11 of the 22 patients. So we're seeing, early on an overall response rate of 50% and a disease control rate. In other words, patients who experience stable disease or a radiographic response as their best response, a disease control rate of 96%. And these numbers fare favorably, acknowledging the limitation in direct head-to-head comparison. When you look at the phase 3 trial of Encorafenib and Cetuximab alone without the immunotherapy, there the overall response rate was reported at 20%. When we looked at survival outcomes, the median progression-free survival as of January 2022 has been 7.4 months, with a median overall survival exceeding 15 months. And again, these results, acknowledging that they're early, are encouraging that there may be some signal for benefit with the addition of immunotherapy agents like Nivolumab to Encorafenib and Cetuximab. The point is well taken that, although our initial findings from our study at MD Anderson are promising, I don't think that this combination is ready to be rolled out into prime time yet for routine use. And certainly there come limitations of single institution, single arm trials. So in order to overcome this limitation, hopefully, and address the question more formally of whether immunotherapy does add meaningful benefit in patients to standard of care treatments in patients with microsatellite stable BRAF mutated colorectal cancer. There is a randomized trial that is going to be coming out in the coming months across the United States initially that randomizes patients to Encorafenib, Cetuximab, with or without Nivolumab in this specific indication. So we will be able to assess more formally, the benefit, if there is a benefit of the addition of Nivolumab in this context.